Welcome to another Deep Dive Ortho. Today, we're tackling quadrilateral space syndrome, QSS, a condition that, well, it continues to challenge even experienced orthopedic professionals, doesn't it?
It certainly does.
Especially when it comes to those high-performing athletes with that persistent, frustratingly vague shoulder pain.
Yes, exactly.
It's where subtle anatomical nuances can lead to major functional limitations, and, truly understanding it deeply makes all the difference. I'm genuinely excited to dive into this today. Your clinical insights here are, well, truly invaluable for our listeners. Our mission for this deep dive is really to unravel the complexities of QSS, pushing past its rare label, if you like, to equip you with the knowledge to spot it, understand it, and manage it effectively, particularly in your athletic patients. We'll be dissecting recent clinical observations and challenging some perhaps established thinking, aiming for genuinely actionable insights for your practice.
Thank you. It's a privilege to be here. And you've hit upon a crucial point right at the start. Overlooking quadrilateral space syndrome, unfortunately, often leads to prolonged patient suffering and a series of ineffective interventions.
Right.
It's a condition that truly tests our diagnostic acumen, and its impact on an athlete's career, or indeed an individual's quality of life, can be profound if it's not correctly identified and managed.
Okay, let's unpack this then. For those of us who perhaps need a quick reorientation on the specifics of this, well, often overlooked diagnosis, what exactly is quadrilateral space syndrome? And where precisely is this quadrilateral space located within the shoulder? The anatomy here really is paramount, isn't it?
It absolutely is paramount. Understanding the anatomy is completely foundational to grasping this condition. So quadrilateral space syndrome, QSS, is essentially a painful disorder of the shoulder, and it stems from the entrapment of two critical structures, the axillary nerve, the AN, and the posterior humeral circumflex artery, the PHCA.
Yep.
And this entrapment occurs within a very specific, rather confined anatomical region in the shoulder, which we refer to as the quadrilateral space, or QS.
Right.
To give you a clearer picture of its boundaries, imagine a compact, sort of box-like area tucked deep in the back of the shoulder.
Okay.
That's our quadrilateral space. Think of it as being nestled posterior and inferior to the glenohumeral joint. Its upper border is the lower margin of the teres minor muscle, and its lower border is the upper margin of the teres major muscle. Medially, it's defined by the long head of the triceps brachii, and laterally, its boundary is the surgical neck of the humerus.
So quite tightly defined.
Very tightly defined. It's a tight squeeze in there, which is precisely why compression is such a significant issue.
Got it.
Now, as for its contents, these are vital. The axillary nerve, a crucial branch originating from the C5 and C6 nerve roots, traverses this space. This nerve is responsible for innervating two key muscles, the deltoid, which is essential for shoulder abduction, and the teres minor, a rotator cuff muscle involved in external rotation. The axillary nerve itself divides into three distinct fascicular groups within this space, each serving different fibers of the deltoid and teres minor. It also provides sensory feedback to the shoulder joint. Interestingly, there are anatomical variations to bear in mind. For example, in approximately 14% of individuals, the long head of the triceps brachii can be partially or entirely innervated by a branch of the axillary nerve.
Oh, interesting.
Which can add another layer of diagnostic complexity if we see triceps issues perhaps presenting alongside.
Right.
Historically, QSS was first described by Cahill and Palmer back in 1983. So while it's been recognized for some time, its elusive nature often means it's still not the first diagnosis that comes to mind in many clinical settings.
So easily missed.
Yes. From an epidemiological standpoint, QSS is genuinely considered uncommon, which significantly contributes to diagnostic delays and or frequent misdiagnosis. However, while rare in the general population, it does have a notable predisposition for a specific demographic. We predominantly see it in young male athletes, typically between 20 and 40 years old, who are involved in overhead sports.
Okay, so the classic throwing or serving athletes.
Precisely. Think of athletes like swimmers, tennis players, volleyball players, and baseball players, essentially. Anyone whose sport involves repetitive, powerful shoulder movements, particularly those involving that late cocking phase of throwing or serving.
Right.
To give you a sense of its prevalence within these specific cohorts, some studies have estimated it to be around 2.2% in beach volleyball athletes, for instance.
Which isn't insignificant in that population.
No, exactly. It might seem like a small percentage overall, but within a high-risk group, it's quite significant and certainly something we should be actively aware of. The reason athletes are at a higher risk is precisely due to the dynamic stress placed on the axillary nerve from repetitive shoulder abduction and external rotation, or AER, movements.
Right, ER.
These repeated motions, especially at the extremes of range, can lead to chronic microtrauma and compression within that confined quadrilateral space.
That deep dive into the anatomy really sets the stage, and given its rarity, as you say, and the overlap with so many other more common shoulder conditions, it sounds like diagnosis is a real puzzle for clinicians.
It is a real puzzle.
So what are the typical ways patients present, and what are those initial, perhaps non-specific symptoms that might inadvertently lead us down the wrong diagnostic path?
Indeed, the clinical presentation of QSS can be incredibly deceptive, often mimicking other more common conditions. Patients usually present with initial, vague, and often nonspecific symptoms. The most common complaint is persistent posterior shoulder pain. And this can be diffuse, difficult for the patient to pinpoint,
Right.
making it challenging for us to interpret. This pain can also often be worse at night, which can sometimes be a distinguishing feature, perhaps differentiating it from conditions that might ease with rest.
Okay, nocturnal pain. That's a useful flag.
It can be. Beyond this general pain, we actively look for other key neurological signs. Patients might describe non-dermatomal paresthesias that's tingling, numbness, or a pins and needles sensation, typically along the lateral shoulder and arm. Crucially, there's often point tenderness directly over the quadrilateral space itself upon palpation. When that's present and specific, it can be a highly indicative finding.
Right. Pressing on the spot reproduces the symptoms.
Exactly. Another subtle but significant sign is isolated deltoid, or tears minor atrophy. This atrophy can sometimes be, well, silent, meaning it's present without significant pain initially, or it might be quite isolated, making it easy to miss if not specifically looked for.
So you really need to compare sides carefully.
You do. You might also observe shoulder external rotation weakness, which could point to tears minor involvement. Now, the primary reason diagnosis is so challenging is precisely this mimicry. Its symptoms frequently overlap with far more common shoulder pathologies, leading to what we call diagnostic mimics. Conditions like subacromial impingement, rotator cuff tears, posterior labral injuries, glenohumeral instability, suprascapular nerve entrapment, cervical radiculopathy referring pain to the shoulder, or even thoracic outlet syndrome.
The usual suspects, then.
The usual suspects, yes. And this frequent misdirection can lead to diagnostic delays and, unfortunately, potentially unnecessary interventions, such as subacromial decompressions, before the correct QSS diagnosis is established. We've all seen cases, I'm sure, where multiple interventions have failed because the primary diagnosis was missed.
Absolutely. Frustrating for everyone involved.
Very much so. Furthermore, when the posterior humeral circumflex artery is significantly affected, the condition can present as Pitcher syndrome.
Ah, the vascular side.
Yes. This broadens the clinical picture to include vascular symptoms like thrombosis, aneurysms, embolisms, and even digital or hand ischemia.
Gosh, so quite serious potential consequences there.
Potentially very serious. So the differential diagnosis goes beyond just nerve entrapment to also consider vascular compromise, which can lead to more acute and severe presentations requiring urgent attention. This isn't just about pain. It can be about limb viability in extreme cases.
That's a comprehensive overview of the diagnostic challenge. It really highlights how elusive QSS can be in the clinic. So if we understand what QSS is and how challenging it can be to spot, let's now peel back another layer. Why does this compression happen? What are the underlying mechanisms you commonly see in your practice that lead to this syndrome? And how does that specific mechanism of injury influence the clinical picture we've just discussed?
That's a crucial question. The pathogenesis of QSS is indeed multifactorial. There isn't just one single cause, but rather several factors that can contribute. The primary underlying mechanism, though, regardless of the specific etiology, is the compression and reduction of the quadrangular space, which then impinges upon the axillary nerve and, often concurrently, the posterior humeral circumflex artery.
Right. Space gets smaller, things get squeezed.
Precisely. Let's delve into the most common causes we see. First, and frequently cited as the primary culprit, are fibrous bands.
Fibrous bands, like scar tissue.
Essentially, yes. Adhesions that form due to repeated microtrauma within the quadrilateral space. They are frequently observed, particularly in cadaveric studies and during surgical exploration, often forming between structures like the long head of the triceps and the teres major. These bands can significantly decrease the cross-sectional area of the QS, especially during shoulder movement, leading to dynamic compression. Imagine a restrictive belt tightening around the nerve with every movement.
Okay, so movement makes it worse.
Often, yes. Secondly, muscular hypertrophy plays a crucial role, particularly in competitive athletes. The significant muscle bulk around the shoulder, especially in the teres major and triceps,
All right.
can dynamically compress the nerve and artery during repetitive movements. This is a classic dynamic cause of compression. The muscle itself becomes the source of impingement when it bulks up and contracts repeatedly.
So the athlete's own strength works against them in a way.
In a manner of speaking, yes. Then we have space-occupying lesions. These are physical masses that can directly compress the structures within the quadrilateral space.
Like cysts or tumors.
Exactly. Examples include paralabral cysts, which are often associated with inferior labral tears, osteochondromas, lipomas, axillary schwannomas, and even venous plexus anomalies. These can exert a static compression, a constant pressure on the nerve and artery, regardless of movement.
Got it. Fixed pressure.
Then, less commonly, trauma can be a direct cause. This might involve scapular fractures or shoulder dislocations that disrupt the anatomy of the space, leading to direct compression or later scar tissue formation. And lastly, there are iatrogenic causes, where scarring or tight fibrous bands might form post-surgery in the region, leading to new or persistent compression, perhaps after previous shoulder procedures.
Okay, that covers quite a range of possibilities.
It does. Now, focusing on the mechanism of injury in athletes, the critical factor is the specific athletic movements they perform. The greatest amount of compression often occurs when the arm is positioned in that late cocking phase of throwing, or during a serve in tennis or volleyball. This involves extreme abduction and external rotation, AER.
That AER position again.
Yes. It's in this vulnerable position that the anatomical structures, particularly those fibrous bands or hypertrophied muscles, can maximally impinge on the nerve and artery. Think of a baseball pitcher at the peak of their windup. That extreme position forces the structures into a very confined space.
I can picture that.
Repetitive AER movements, as seen in volleyball, baseball, or swimming, can lead to both neurogenic and vascular symptoms. In neurogenic QSS, the pain and neurological deficits are specifically aggravated by these movements because the nerve is being repeatedly squeezed. In vascular QSS, the turbulent blood flow caused by this compression can lead to more severe outcomes, such as thrombotic occlusions or aneurysms, which is what we see in pitcher syndrome. The repeated compression and release can damage the arterial wall, predisposing it to these complications, which can be acutely devastating.
Okay, so that really links the why to the what in terms of symptoms.
Absolutely. And this brings us neatly to the spectrum of symptoms, highlighting the distinction between neurogenic and vascular QSS. Neurogenic QSS, NQSS, presents with a constellation of symptoms. We typically see posterior shoulder pain, which, as we discussed, is often vague and can be worse at night. Patients report non-dermatomal paresthesias along the lateral shoulder and arm. There's a consistent tenderness upon palpation directly over the quadrilateral space. And importantly, isolated deltoid and/or curious minor atrophy is a key sign, which can sometimes be surprisingly painless and therefore easily missed.
Right.
You might also find shoulder external rotation weakness and occasionally fasciculations of the posterior deltoid or long head of the triceps brachii, indicating nerve irritation.
Okay, so primarily nerve-related signs.
Primarily. Conversely, vascular QSS has distinct and potentially more acute symptoms. These can include thrombosis, embolisms, pallor, coolness, and cyanosis of the hand and digits due to compromised blood flow.
Much more urgent presentation, potentially.
Often, yes. These acute presentations necessitate a different and often more urgent management approach, sometimes requiring immediate vascular intervention. So the underlying cause and the predominant structure affected nerve or artery directly dictate the specific constellation of symptoms you'll observe clinically. It's not a one-size-fits-all presentation.
That's a really clear and detailed explanation of the underlying mechanisms. It highlights why it's so critical for us as clinicians to keep QSS in mind, especially when faced with those complex shoulder pain presentations in overhead athletes. So once we have the syndrome on our radar, how do we actually go about confirming the diagnosis, given its often subtle presentation and the challenge of distinguishing between neurogenic and vascular forms? This sounds like a diagnostic tightrope walk. What clinical signs and examination techniques are most indicative, and how do we use advanced imaging to truly pin down this elusive condition?
You're absolutely right. It is a tightrope walk. The diagnostic process for QSS really begins with a comprehensive clinical assessment. This is the cornerstone. Before even strongly suspecting QSS, we must meticulously rule out more common causes of posterior shoulder pain. This includes thoroughly assessing for posterior labral injury, glenohumeral instability, suprascapular nerve entrapment, rotator cuff pathology, cervical radiculopathy, and even conditions like thoracic outlet syndrome.
A thorough differential is key.
Absolutely. A detailed history, including the patient's athletic activities and specific aggravating movements, is paramount. We need to be like detectives, piecing together the subtle clues.
Okay. So the hands-on examination. What are the key things to look for?
In terms of key physical examination findings, point tenderness over the quadrilateral space is almost universally present in QSS and is a highly indicative sign. Palpation in this specific area may directly reproduce the patient's lateral shoulder pain or paresthesias.
Right. That localized tenderness is crucial.
It really is. Another important, though sometimes subtle, finding is atrophy of the teres minor and/or deltoid muscles.
Mm.
As we discussed, this can be silent or isolated, so clinicians must actively look for it, perhaps comparing bilaterally or asking the patient if they've noticed any asymmetry.
Careful inspection.
Careful inspection, yes. We also observe pain exacerbation with active and resisted abduction and external rotation, AER, of the arm. A diagnostic mover often employed is holding the arm in this provocative position for 1 to 2 minutes, which can bring out the symptoms.
The AER provocation test.
Precisely. Specific tests, such as Porcellini's test, can also be useful if a posterior labral tear is suspected, as these can sometimes be a triggering factor for QSS or coexist.
Okay. Beyond the physical exam.
Beyond the physical exam, we have the diagnostic Lido test. This involves an ultrasound-guided injection of typically 5 milliliters of 1% plain lidocaine directly into the quadrilateral space.
The lidocaine injection, how useful is that?
The diagnostic value here is significant. If the patient experiences substantial pain relief following this injection, it is highly suggestive of QSS. However, and this is a crucial caveat, this procedure absolutely requires an expert ultrasound technician or a clinician with significant experience in musculoskeletal ultrasound.
Why is that so important?
Because if it's not performed precisely, the anesthetic could easily spread to other nearby nerves, such as this suprascapular nerve, leading to misleading positive results and further diagnostic confusion. The precision is absolutely key to its diagnostic specificity.
Got it. Expert hands needed for that one. What about imaging?
Moving on to imaging insights, these are vital for confirmation and ruling out other pathologies. Radiographs are always the first step, primarily used to rule out other conditions like fractures or bony masses or subtle osteochondromas.
Standard x-rays. Usually normal in QSS.
Usually normal, yes, but they serve an important exclusionary purpose.
Right. And MRI.
Magnetic resonance imaging, or MRI, is incredibly useful. Its primary utility is in evaluating for those space-occupying lesions we mentioned, cystic ganglions, paralabral cysts, lipomas, or other masses that might be causing compression. More subtly, MRI can demonstrate denervation changes. This typically presents as muscle edema in the early stages.
Okay.
Or atrophy of the teres minor and deltoid muscle in more chronic cases. Specifically, diffused belly edema on SDR images, that's a short pup inversion recovery sequence, can appear as early as 2 weeks after denervation, often being one of the first imaging signs of nerve distress.
So MRI can pick up nerve changes relatively early sometimes.
Sometimes, yes. We often advocate for MR arthrograms when labral lesions are suspected, as they provide even more detailed images of the quadrilateral space and any associated labral pathology, helping us identify any concurrent issues that might need addressing.
Makes sense. What about EMG, nerve conduction studies?
Electromyography EMG can also be a valuable tool, but it definitely has its limitations. EMG is not always indicative at rest if the compression is dynamic and intermittent.
So a normal resting EMG doesn't rule it out.
Exactly. Therefore, it's often suggested that EMG be performed during AER movements or immediately after sustained provocative positioning to try and capture this dynamic compression. That's a key point for those cases not showing up at rest.
Right, a dynamic EMG test.
When positive, EMG can show axillary nerve involvement, with findings like spontaneous fibrillation potentials indicating active denervation or reduced compound muscle action potentials, CMAT, suggesting chronic neurogenic damage. It's also very helpful in excluding suprascapular nerve entrapment, which can have similar symptoms but originates from a different nerve.
Good for differential diagnosis too, then.
Yes. And finally, for vascular QSS, arteriography is the gold standard investigation. It's used to visualize any lesions in the posterior humeral circumflex artery, such as aneurysms or occlusions. Crucially, dynamic angiography, performed with the arm in symptomatic positions, like AER, can reveal compression or occlusion that might not be evident at rest, truly capturing the pathological event.
Okay, so specific tests for the vascular side too.
Yes. These comprehensive diagnostic tools have led to a proposed classification system, which is immensely helpful in guiding both diagnosis and treatment. We classify QSS into two main types. Firstly, static QSS. This type is caused by fixed structural entities that exert external compression. This includes the tenacious fiber strands we discussed earlier,
Right, the scar tissue.
often forming as adhesions from repeated microtrauma. Other static causes are paralabral cysts, lipomas, osteochondromas, axillary schwannomas, or venous plexuses. These are constant sources of pressure.
It's blockage.
Exactly. Secondly, we have dynamic QSS. This type is associated with muscle hypertrophy around the quadrilateral space, particularly common in competitive athletes. In these cases, repetitive abduction and external rotation movements are what cause the dynamic entrapment. Here, the compression comes and goes with specific movements.
Triggered by activity.
Precisely. This classification really highlights that relying solely on static isometric tests is insufficient for comprehensive evaluation. Clinicians truly need to integrate biomechanical analysis of athletic movements and dynamic tests into their diagnostic approach to fully understand the underlying mechanism and guide appropriate management. It shifts our thinking from a snapshot to, well, a movie of the pathology, if you like.
That's a truly profound takeaway for our listeners. Recognizing whether QSS is static or dynamic fundamentally shifts our diagnostic lens and, critically, our treatment approach. Knowing this, let's now turn our attention to management. What are the current approaches? Is conservative management always the first line? And when should clinicians consider escalating to surgical intervention, particularly given this static versus dynamic classification?
Indeed. Once a diagnosis of QSS is confirmed, the typical treatment trajectory almost always begins with conservative management as the first line of treatment. The goal here is to alleviate symptoms and promote functional recovery without immediate surgical intervention, especially in dynamic cases or those caught early.
Okay, so start conservatively. What does that involve?
The components of conservative management are quite comprehensive. Firstly, activity modification and restriction are absolutely crucial. Patients must avoid movements that provoke their symptoms, particularly overhead activities involving abduction and external rotation.
Stop the offending activity.
Essentially, yes. This often means stopping or significantly limiting the inciting sports or activities for a period, which can be challenging for athletes, naturally, but is absolutely necessary for allowing the nerve or artery to recover.
Makes sense. What about medication?
Alongside this, pharmacological interventions are used for symptom relief. Non-steroidal anti-inflammatory drugs, NSAIDs, are a common first choice for pain and inflammation. In some more refractory cases, as we saw in a case series we'll discuss, other medications such as opioids or pregabalin might be used to target neuropathic pain.
Right, for the nerve pain component.
Exactly. Acetyl-L-carnitine was also noted in one instance, suggesting perhaps a role for nerve-supporting supplements to aid recovery, though the evidence there is still developing.
Okay. And physical therapy.
The backbone of conservative treatment is a comprehensive rehabilitation program or physical therapy. This program focuses on several key areas. First, strengthening scapular stabilizing muscles, along with the posterior deltoid, to improve overall shoulder mechanics and support, potentially offloading the compressed area.
Improve the foundations.
Precisely. Then, restoring shoulder rotator balance, specifically addressing any imbalances between internal and external rotation strength and flexibility. This is vital in overhead athletes.
Critical for those efforts.
Absolutely. Also, preventing scapular protraction and improper mobility, which can contribute to the compression by altering the dimensions of the quadrilateral space. Good scapular control is key. Then there's compensatory strengthening. For patients with anterior deltoid weakness, reinforcement of the pectoralis major and subscapularis muscles is vital to compensate for lost function and maintain anterior shoulder wall strength, allowing for a better force couple.
Using other muscles to help out.
Yes. Soft tissue techniques like transverse friction massages and active release techniques can be used to address stiffness and fibrous restrictions around the quadrilateral space, potentially freeing the nerve manually. Stretching. Self-assisted stretching exercises of the posterior capsule can also be beneficial in improving overall shoulder range of motion and reducing tightness. And finally, muscle trophism. To maintain muscle mass and function in affected muscles like the anterior deltoid and teres minor, recruitment exercises and even electrostimulation might be employed to prevent or reverse atrophy.
So a really multifaceted physio approach.
Very much so. With this robust conservative approach, most patients typically see significant improvement within, say, 3 to 6 months. In many documented cases, complete symptom resolution has been achieved without the need for surgery, especially in dynamic QSS cases where muscular balance and controlled movements can alleviate the pressure.
Okay, so conservative treatment works for many, but when does surgery come into play?
Right. As for surgical intervention, the decision of when and how to proceed is critical. Surgery is indicated primarily when conservative management, even a robust and prolonged trial, fails to provide adequate relief. Historically, this sufficient trial has often been cited as a minimum of 6 months.
6 months. Is that still the standard? We'll come back to that.
We will. Other clear indications include the presence of severe or progressive symptoms, such as significant weakness and functional disability, that are not responding to non-operative measures, or if there's clear evidence of ongoing nerve damage on EMG, for instance. And crucially, surgery is also considered if there's clear identification of a space-occupying lesion, such as those tenacious fibrous bands, large cysts, or tumors, that is unequivocally causing persistent static compression. These are unlikely to resolve with conservative treatment alone.
Makes sense. If there's a physical block, you need to remove it.
Precisely. Regarding surgical techniques for neurogenic QSS, the primary approach is open quadrilateral space decompression.
How is that done?
This typically involves a lateral decubitus position with a 3 to 5 centimeter incision centered on the posterior border of the deltoid. The objective is gentle elevation of the deltoid, careful identification and blunt dissections of the adipose tissue within the quadrilateral space, and then isolation of the axillary nerve and its various branches. The ultimate goal is to meticulously free any fibrous lesions or other structures adhering to the nerve, ensuring complete decompression. It's paramount to avoid damaging the posterior circumflex artery during this process.
Tricky dissection, I imagine.
It requires careful technique. An intraoperative electroneurostimulator can be very useful here to confirm the precise location of nerve branches and assess their function, providing real-time feedback during the dissection.
Okay, and if there's other damage, like a labral tear?
Yes, in some cases, if an associated labral tear, such as a posterior labral peelback lesion, is present and thought to be contributing to the pathology or symptoms, it can be fixed with anchors during the same procedure. This allows for a single surgical event to address multiple contributing factors, as we observed in one of the clinical case studies.
Address everything at once.
Where appropriate, yes. For vascular QSS, surgical or interventional approaches are quite distinct and often more urgent. Aneurysm resection or catheter-directed therapy, such as thrombolysis or thrombectomy, may be necessary, particularly in acute presentations involving thrombosis or embolisms, where immediate restoration of blood flow is critical.
Different goals, different techniques.
Exactly. Following surgical intervention, post-operative rehabilitation is absolutely essential and must be tailored to the individual patient and the specifics of the surgery.
What does post-op rehab look like?
Key initial steps include immediate pendulum exercises and early activation of the parascapular and rotator cuff muscles to restore shoulder balance and prevent stiffness. The overarching goal is early mobilization to limit the formation of new fibrous bands or adhesions.
Get things moving early.
Yes, carefully. Specific protocols often involve sling use, perhaps with a 15-degree abduction pillow for about 3 weeks, followed by a gradual progression of passive and active range of motion. We're often careful to avoid internal rotation initially, depending on what was done. Strengthening then progresses, starting with external rotators, the deltoid, and humeral head depressors, before moving on to internal rotators. Importantly, progression to sport-specific activities should only occur once balance strength is confirmed, often via objective measures like dynamometric testing, to ensure the shoulder is robust enough for high-demand activities and to prevent recurrence or secondary issues.
A careful staged return.
Absolutely essential.
That's a very clear pathway from diagnosis through to treatment and rehab. It's evident that the decision-making process for QSS is nuanced, often requiring a patient approach and a keen eye for when conservative measures are insufficient. Now, to truly bring this to life, you've reviewed a fascinating case series. Could you walk us through some of these cases and, crucially, what key clinical pearls we can draw from them for our own practice? What common threads and unique patterns emerged?
Yes, this case series provides truly valuable insights into the varied clinical presentations and responses to treatment for neurogenic QSS. We examined 4 patients, all of whom were competitive overhead athletes, ranging in age, primarily male, but importantly also including 1 female athlete. All were ultimately diagnosed with neurogenic QSS. Vascular QSS is considerably rarer in our clinical experience, The primary outcomes we considered were pain relief and functional recovery. The good news is that all patients eventually returned to their prior strength and performance levels, achieving complete active and passive range of motion, albeit through different rehabilitation programs and treatment paths, which highlights that successful outcomes are indeed achievable, even if the journey varies.
That's encouraging. So tell us about some specific cases.
Okay, let me walk you through a couple of illustrative cases that highlight static QSS and the success of surgical intervention. Case 1 involved a 54-year-old male tennis player. He presented with persistent posterior shoulder pain, paresthesias, and significant limitations impacting daily activities, sport, even sleep. His visual analog scale, VAS scores, were high, 6 at rest, jumping to 9 with abduction and external rotation movements.
Pretty severe symptoms.
Yes, and they'd worsened insidiously, a classic progression often seen in nerve entrapments. His diagnostic journey was quite telling. The Lido test was positive, highly suggestive of QSS. But interestingly, his initial EMG was normal.
Ah, that point again.
Yes, underscoring that early nerve compression might not always show up on a static EMG. His initial MRI also appeared normal. However, a repeat scan 2 months later showed progressive atrophy of the teres minor.
So the imaging findings evolved over time.
They did, highlighting that findings can evolve and may not be immediately evident. His treatment path initially involved conservative measures, NSAIDs, opioids, pregabalin, physical therapy. Crucially, these were ineffective and, in fact, worsened his symptoms, leading to an interruption of therapy.
A clear failure of conservative care.
Absolutely. This strongly suggested a tenacious fixed entrapment that wasn't responding. So 4 months after symptom onset, he underwent surgical decompression of a fibrous band that was clearly entrapping the teres minor branch of the axillary nerve. During the same procedure, an associated posterior labral peelback lesion was also fixed.
And the outcome?
The patient reported immediate and complete pain relief post-surgery. Following a structured rehabilitation program, he successfully returned to play. While 2 procedures were performed simultaneously, the dramatic relief of his specific neuropathic pain pointed clearly to the QSS decompression as the primary driver of improvement.
That first case really reinforces the idea that some forms of QSS, the static ones, are just not amenable to conservative care, and that early imaging can be deceptive. It's almost a call to action not to give up on the diagnosis just because the first MRI is clear.
Precisely. And case 4 echoes this. It involved a 36-year-old male volleyball player and amateur cyclist. He presented with progressive anterior deltoid atrophy, pain, and weakness following a resolved adhesive capsulitis, along with hypoesthesia in the axillary nerve distribution.
Another athlete with atrophy.
Yes. His diagnostic findings included an EMG showing chronic neurogenic damage evidenced by reduced CMP and an MRI showing teres, minor edema, and adipose degeneration. His initial conservative treatment, including physio and various medications, failed over 6 months, with symptoms worsening. He also underwent surgical decompression, where a large fibrous band between the long head of the triceps and teres major was removed. The outcome was striking. He experienced immediate relief from shoulder pain and recovered deltoid strength, 55 MRC scale, from the very first day post-surgery, with continued improvement.
Wow, immediate results like that are quite telling.
They really are. So the key takeaway from these 2 cases, cases 1 and 4, is that truly tenacious fibrous bands causing static compression can render conservative treatment ineffective or even detrimental. They necessitate timely surgical intervention for marked and rapid improvement. It really underscores that sometimes non-operative treatment just won't cut it, and waiting too long might actually worsen nerve damage.
A very important point. But surgery isn't always needed, right? What about dynamic QSS?
Exactly. Now, let's look at an illustrative case of dynamic QSS that saw profound success with conservative management. Case 2 was a 17-year-old male professional volleyball player. He presented with undefined shoulder pain, a significant loss of strength and control during hitting and service actions, and visible anterior deltoid atrophy.
Young athlete, performance dropping off.
Precisely. His shoulder flexion strength was significantly reduced, grade 4 MRC, and his subscapularis was noted to be 40% weaker than the contralateral side, with a clear imbalance between internal and external rotators. His Lido test was positive. MRI confirmed the anterior deltoid atrophy, and EMG revealed inactivity of the axillary nerve during certain tests.
So clear objective evidence. What was the approach?
He stopped volleyball for 8 weeks and underwent a very specific conservative management program. This included strengthening scapular stabilizers, rotator cuff muscles, and crucially, restoring that shoulder rotator balance we talked about. Reinforcement of the pectoralis major and subscapularis was used to compensate for the anterior deltoid weakness.
Tailored physio again.
It's very tailored. After 6 months of dedicated physical therapy, he returned to his previous professional performance levels.
Fantastic result without surgery.
It really was. This case highlights the power of early diagnosis in dynamic QSS. When you can identify the mechanism, likely hypertrophy and dynamic compression in his case, and address it with targeted rehabilitation focused on muscular balance, surgical decompression can indeed be avoided, especially in younger athletes. It's a testament to conservative care's potential if the diagnosis is spot on and the rehab is specific.
Definitely. Any other key cases?
Yes, one more. Case 3 showcases progressive symptoms leading to surgical resolution, even without severe pain initially. This is a 22-year-old female volleyball player. She presented with non-traumatic shoulder discomfort, weakness, and limitation in active forward flexion and abduction, but notably without significant pain being her primary complaint.
Interesting. Weakness without much pain.
Yes. Her anterior deltoid atrophy had been evident for 3 months, and standard rotator cuff tests were negative. Both palpation of the quadrilateral space and the Lido test were positive. Her EMG revealed spontaneous fibrillation in the anterior deltoid and partial teres minor involvement, and MRI noted a hyperintense area around the axillary nerve.
So investigations were positive despite low pain levels?
Correct. Despite 6 months of conservative treatment, including physical therapy and other measures, her symptoms did not resolve, and her anterior deltoid atrophy actually worsened.
Progressive atrophy is the bad sign.
It is. So she underwent surgical decompression of the axillary nerve, releasing fibrous bands from the long head of the triceps to the teres major. Strikingly, from day 1 post-surgery, her strength during isometric tests for the teres minor and deltoid muscles improved significantly, reaching 55 on the MRC scale a month later. Despite some persistent deltoid atrophy on follow-up imaging, her range of motion was complete and symmetrical, and she reported no limitations in daily living or sport activities, returning to play after just 4 weeks of focused rehabilitation.
Wow, rapid functional return despite the residual atrophy.
Exactly. This last case really drives home that functional recovery is paramount. Even without initial severe pain, progressive atrophy and functional limitation can absolutely necessitate surgery, leading to rapid and significant functional recovery. It's a powerful reminder that sometimes the clinical picture, particularly the functional deficits and their progression, should truly guide our decision-making, perhaps even more so than the pain score itself.
Such important clinical lessons there. These cases really reinforce the varied manifestations and highlight the importance of individualized treatment pathways tailored to the patient and the likely underlying cause, static or dynamic. It really brings home the complexity.
Indeed. It requires careful assessment and ongoing evaluation.
Now, as we wrap up this deep dive, it's clear QSS is a condition demanding more attention. What are the major unanswered questions and future directions for research and clinical practice in this area? What still keeps you thinking about QSS?
That's a crucial question, and it points to the evolving nature of our understanding. Firstly, there's the issue of the underestimated prevalence.
You mentioned it's considered rare.
It is, but its true prevalence is almost certainly underestimated. This is due to the inherent diagnostic complexities we've discussed, and importantly, a significant percentage of patients who might be asymptomatic or have very subtle, nonspecific symptoms that never lead to a formal diagnosis. We, as clinicians, need increased awareness to diagnose it properly. I've seen cases, as I'm sure many listeners have, where it's only diagnosed after excluding more common diseases, or unfortunately, after unsuccessful surgery for presumed other conditions. It's often a diagnosis of exclusion that comes late in the game.
So raising awareness is key.
Absolutely. Secondly, there's a significant debate on treatment timing, particularly challenging that established 6-month conservative treatment period before considering surgery.
Right, you flagged this earlier. Should we always wait 6 months?
Well, the case series we just reviewed raises a pertinent question. Should this duration be adhered to rigidly, especially as signs and symptoms are severe and our suspicion of static QSS is high and well-founded, perhaps confirmed by imaging or a very clear history? Delaying surgery might actually worsen outcomes in certain cases with those tenacious entrapments. There's a compelling argument that surgical intervention might need to be considered earlier if specific indicators like clear progressive neurological deficit or severe intractable pain unresponsive to initial management strongly point towards severe or static compression. What's the potential cost of waiting if we're risking irreversible nerve damage?
A difficult balance to strike.
It is. Thirdly, we face the challenge of refining rehabilitation approaches. There's a notable lack of robust, high-quality studies comparing the efficacy of specific physical therapy techniques for QSS. This underscores the critical need for truly personalized rehabilitation programs, tailored precisely to each patient's unique symptoms, their functional needs, and crucially, the underlying cause dynamic or static QSS. A generic shoulder protocol is unlikely to be optimal.
More research needed on targeted physio.
Definitely. And it's also a significant challenge when the intensity of pain is so high that physical therapy cannot even be initiated effectively. This stresses the need for effective early pain management strategies to actually facilitate entry into a rehabilitation program. You can't rehabilitate a patient who's in agony.
Very true. What else?
Another area needing clearer guidelines is defining full recovery in athletes. Currently, clear criteria for what constitutes full recovery, particularly for high-performing overhead athletes returning to elite sport, are still lacking.
How do we know when they're truly ready?
Exactly. We need to move beyond just symptom resolution or achieving full range of motion. We propose the importance of objective measures, such as dynamometric evaluation of bilateral internal and external rotators, to confirm balanced strength before an athlete returns to play. This ensures not just symptom-free movement, but robust functional capacity that reduces the risk of recurrence. We need objective data to guide that return-to-play decision.
Moving beyond subjective reports.
Yes. Looking to future research and clinical implications, it's paramount to integrate biomechanical analysis and dynamic tests into our routine clinical evaluation, moving beyond static isometric tests alone. This is key to identifying dynamic compression and guiding targeted rehabilitation or even surgical decisions. We must also reinforce that ultrasound-guided lidocaine tests, when performed by expert practitioners, are crucial for completing the diagnostic picture, providing that vital objective confirmation in ambiguous cases.
So embracing dynamic assessment and expert-level diagnostics.
Precisely. To conclude, we must advocate for continued robust research to determine the optimal timing for surgical intervention in QSS and to further validate and refine the proposed static versus dynamic classification system. This will undoubtedly improve our diagnostic algorithms and treatment protocols, ultimately improving patient outcomes and, hopefully, reducing the diagnostic odyssey many of these patients currently face.
That truly lays out the road ahead for the orthopedic community. There's always more to learn, isn't there? And that's precisely why we do these deep dives. Well, that was an incredibly insightful deep dive into quadrilateral space syndrome. From its subtle anatomical entrapment to the nuanced diagnostic and treatment strategies, it's clear that a keen eye and a multidisciplinary approach are absolutely key to helping our patients. If you found this deep dive valuable today, please do consider rating and sharing Deep Dive Ortho with your colleagues. Your support helps us bring more expert discussions like this to the medical community. And thank you so much for sharing your profound expertise and practical insights today, especially from that illuminating case series. Your contributions have been invaluable.
It's truly been a privilege to contribute. My hope is that this discussion aids clinicians in their practice, particularly in recognizing and managing QSS more effectively, and ultimately helps more patients find relief sooner rather than later.
Absolutely. And a final thought for you, our listeners. As orthopedic professionals, what subtle signs might you now be looking for in your own patients with unexplained shoulder pain, especially in athletes, that perhaps you might have previously overlooked? Consider how framing the problem through that static versus dynamic classification lens could immediately shift your diagnostic and treatment approach for the better. Join us next time for another deep dive into the world of orthopedics.